This is an interesting tracing that different parts of it get people's attention first. Sometimes people are immediately drawn to the fact that this is complete heart block. We have P waves more than the QRSs. Sometimes they are drawn to these complexes here in the precordium and think that the QRS is 400 milliseconds long. But if you stop to think about what else you would expect to see here, there is no T wave, and then hopefully you recognize that this is actually the T wave and the ST segment is just so elevated that it looks like it's becoming part of the QRS. So this is sort of a prototypical tombstone ST elevation. So sometimes people are drawn to that as an initial finding. But it is really important to go through this in a methodical fashion, because if you only catch the ST elevation, or if you only catch the complete heart block and you don't catch the other, you could be in trouble with that patient later. So looking at this systematically here, our heart rate, at least in the ventricle, is 300, 150, 100, 75, 60, 50. So somewhere between 50 and 60. It also looks like it's probably a wide QRS if you look at ones that don't have this terrible ST elevation. So this is probably a probably a ventricular escape rhythm because of the fact that it's wide. The atria look like they are going a little bit faster. So here's a P wave, here's a P wave, 300, 150, 100. So this is actually sinus, almost tachycardia, with complete heart block. So sinus tach with complete heart block. Axis is not relevant if we think that this is a rhythm coming from the ventricles. We're not going to generate an axis because that's assuming that we've got native AV conduction. There's no PR interval. The QRS is not relevant because it's coming from the ventricles. The QT you can measure, but you really probably want to put them back into normal sinus rhythm first if you can. And we've got other things to worry about when it comes to the ST segment anyway. So we've got this anterior ST elevation. This is a medical emergency. We need to take them to the cath lab right away. And then, so why does somebody have both complete heart block and ST elevation at the same time? Well, the heart block could have been pre-existing. They've got a reasonable enough ventricular rate that perhaps they didn't notice. That's one possibility. The other is that the ST elevation could cause ischemia of the AV node that can either transiently or permanently disable it. Now, normally the AV node gets a dual blood supply from both the anterior and the inferior circulation, but sometimes that doesn't happen. Sometimes the LAD actually wraps around the apex to supply the PDA. Sometimes the left main and left circ are dominant, the right is very small, and so a left main lesion could do something like this. So you've got several different potential explanations. The important thing to note is that this patient, while having PCI, while having a stent put into their LAD or their left system, wherever it needs to be put in, probably warrants having a temporary pacemaker put in, even if they're not using it now. This ventricular escape rate might not work in the long term, and you would hate for them to lose their escape rhythm in the middle of the night and have to put in an emergency temporary pacemaker. So putting a temporary pacemaker in for a couple of days wouldn't be a big deal. This person is probably going to be in the ICU for that period of time anyway, depending on how well they're doing clinically otherwise. And then if the AV node recovers, then you'll be able to see that. You can set the pacer such that the native conduction is preferentially seen. And if it recovers, then you don't need to do anything. If it doesn't recover, this person may also need a pacemaker in addition to a stent. So, anterior MI with complete heart block.